stuff falls into place. The same mechanism works. The trick is, how do you personalize stuff? Well, one answer is obvious. Each of us, let's analyze the 3 billion base pairs in our genome and figure out what to do. But the problem with that from a machine learning point of view is if you collected data from every person that ever lived, you still wouldn't have enough to learn this robustly. So you need to do something a little smarter, and also something that you might be able to do in the short run while waiting for the revolution in genomics and proteomics to occur. So I'm going to take a case where this is an actual deployed system in Europe at several sites, where we're going to look at a patient with lung cancer. This is a patient who's been diagnosed with lung cancer. Thank you. And the point is, if, let's say, God forbid, I got lung cancer and say one of my colleagues got lung cancer, today we would be treated, stage 3 lung cancer, we would be treated identically. And we'd be treated identically regardless of the fact that, we may have a different racial background, different ages, maybe different gender. The tumor may be of a different size in a different location and of a different pathology. It may be, and of course, then you start going down into, the fact that our genome is different. So how do you develop plans that are personalized, and then how do you update them? So a simple thing is, if you look at radiation therapy, the way radiation therapy is done, so cancer is actually fairly simple. If someone's got cancer, we can cure your cancer. We can guarantee to kill every cancer cell. Unfortunately, the treatment will also kill the patient, because what you have is the red curve is the probability of tumor control for a given radiation dose. And the blue curve is the probability of normal tissue damage. And the reason it's less is that typically what you do is you fire, if a patient has a tumor in the chest, you'd fire beams in from different angles, so the damage to the spine and the lung is less than the cumulative damage to the tumor, one hopes. The problem is these curves were built based upon studies done in the 50s and 60s, where people had no idea how much radiation to give. So if you look at the study, they would say, okay, we should give this patient this much, and then they'd flip a coin and give the next patient 4 times as much. It wasn't irresponsible medicine. They just didn't know, and they've obviously done stuff that's very useful. But look at the error bars in those curves. They are pretty huge. And here's an actual patient whose curve might be very different, and if you gave that patient this value, you'd be out somewhere over here where you'd have a very low probability of tumor control when you could increase it. So this is just a very simple example of how you can personalize treatment by figuring out how much radio resistance they have and what kind the tumor is, which is not done today. Here's a study of something we did. We took data from an institution. We learned a couple of models using logistic regression methods. These are ROC curves. We then went through about 40 papers by hand and built modules to sort of understand what the knowledge said about doing this. So we had now 3 sets of models. And then we built a combined model using a very simple method. If the data point was similar to data points we'd seen earlier, we trusted the data more. If it was very different, we trusted the generalized knowledge less. And it was just a smooth continuum. And as you can see, you got significantly improved predictive performance in the ROC. So the next step we said was, how good is this? Fundamentally, prediction is the key. Predicting the efficacy of a treatment, predicting patient survival, patient side effects, is the key to medical decision making. You give a treatment that you believe will do well. That's why you pick a treatment. So we now asked 8 oncologists to look through 30 cases. And as you can see from another institution, so these were cases of patients who had been treated more than 2 years ago, and we asked them to predict the 2-year survival of a patient given a treatment. And they could have done 0, 1, they could have done a probability, they could do whatever they liked. And as you can see, the ROC of our curve was significantly better than the ROC of the radiologist. And this was when sort of a switch got thrown at the institution. People went from being very skeptical about all this data mining crap, as they used to call it, to wow, this is amazing machine learning decision support. And as a result, we are going to do what I believe is the first ever personalized prospective trial where our system will actually be used on patients coming in to evaluate under IRB. But this is actually going to be used, and it's very, very exciting. Thank you. Okay, so I'm just going to zoom through the rest. So the idea is simply to take the models, apply them, and I'm going to show you how that works based on patient data. And then the other piece which we're missing is one could simply develop surrogate markers. So the way it's done today is you apply a treatment and then you wait. Well, if you can develop surrogate markers that after 7 days show you that with high probability your treatment's not working, biomarkers, blood markers, then you would simply change the treatment, right? And you could say, all right, I'm now going to accept a much higher risk of side effects. So really quickly, here's a system that's actually being used. There are a number of patient factors that are pulled out. As you can see, they have to do with demographics, they have to do with tumor factors, and they have to do with measurements from the various images. There's a treatment. We plugged in our models, which says the probability of survival, outcomes, and side effects. And what physicians can do is they can say, okay, let me try changing the treatment from 60 to 65. And as you see now, the probability of survival has jumped from 34% to 50%. But the probability of side effects, and these are serious side effects, that you'd be in a wheelchair for the rest of your life and need oxygen, has gone from 11% to 14%. But now it's not necessarily clear what the right choice is, but at least you can quantify it. But you also know that if you went to 70, it doesn't increase, at least based on our model, the probability of survival, but does increase the probability of side effects. And again, these are the things that we're going to validate in our prospective trial. And in Europe, because you could never do this sort of stuff in the United States. But just to show something cool from the field of genomics and proteomics we've done, we believe we've developed a signature that will predict acute hypoxia. And this is extremely important because this tells you the prognosis of a patient to treatment. Hypoxic tumors are those that are starved of cancer, of oxygen, and grow very fast and don't respond well to traditional methods. So we developed this based on experimental data, and we applied it to 4 publicly available data sets, which we've never seen, on different cancers. And as you can see, the red curve is the patients who do have the signature, and the blue is don't. The blue are the ones who don't. So here's a simple test based on about 20 genes, be done on a chip, cost about €5 to do. And here's what you know. If the patient's on the blue curve, you probably want to continue with the traditional treatment. If the patient's on the red curve, you have the option now of saying either refuse treatment, give that to the patient, or saying we're going to try something very aggressive. We're going to double the radiation, we're going to risk side effects, or enroll in a clinical trial, etc. But again, these are options that are available. And this is how we're starting to get into personalized medicine, not necessarily looking at the whole genome and proteome, but looking at pieces here and there, looking at biomarkers, etc. We're in the process of creating a network across Europe with 6 sites, and we have several sites across the world where we've built a grid where our data will be shared, where the data will be shared to do machine learning, but still stay behind the walls of each institution to learn these models. And we're getting a lot of support because a good data set is 300 patients. That's like, an institution. And you can imagine now the complexity of trying to learn this. All right. Here's an example of a plan. And done. And as you can see, there are lots of open positions. So you want to help save lives? Talk to us. Thank you.